Hi, everybody. Thanks so much for joining. I'll introduce myself very briefly, but if I can ask, I put a QR code that's a very brief Google form that just asks for your name and a little like, I am here. So if you could sign in, we're just trying to track people who attended the lecture versus watched it virtually. But my name is Lauren Puckett. I am one of the antimicrobial stewardship / infectious diseases pharmacist at Lucille Packard Children's Hospital, and I'm here today to do the pharmacist portion of the education around the CORIZA project. Okay. So a quick background on the project, and really first starting at a sort of big overview, like big picture of why we're talking about this. So most of the antibiotics, like 95% of pediatric antibiotic use actually happens in the outpatient setting, with most antibiotics being prescribed for common acute respiratory tract infections. So otitis media, CAP, sinusitis, strep pharyngitis. Certainly, as you might expect, there's very wide variations in practice that come with this across countries, regions, clinics, providers. And so because of that, we feel that there's a opportunity to reduce both overall use and try and um, use first-line antibiotics. So where do this CORIZA acronym fit into this? So CORIZA is our HSII funded implementation project, which stands for Clinical Optimization of Respiratory Infections, zeroing in antibiotics, because all studies have to have a cool name nowadays. Goal of this project is to affect sustained and meaningful practice change with a set of implementation strategies to basically uh, do antibiotics better for children with ARTI. Our major outcomes we're looking for are really to prescribe antibiotics only when they're necessary, and then when they're being prescribed, make sure that we're using the right antibiotic, the right dose, duration, choice, etc., while also making sure that we are maintaining or improving baseline rates of treatment failure and making sure that we're not increasing adverse drug events. So where do y'all fit into this? So we think that ED pharmacists are very, very important, both as a fellow pharmacist and knowing the role of pharmacists that play in education for providers. So I'll say providers are getting their own lecture series and education, but also knowing that you're positioned in a way to help intervene if you see that there is a opportunity for a prescription being sent. So it looks like there's three parts to this, but I am going to try and get through them as quickly as possible. And really, most of the meat of this is sort of in that part 1 and 2. So first, wanted to level set for all of us and just give some overall antibiotic dosing education. Because these are respiratory tract related algorithms, there's going to be very similar antibiotics, very similar doses throughout. So a lot of what is said about amoxicillin dosing applies basically across the board. Then we're going to review some algorithms and then just general ID resources that I hope are useful for you all. So first, antibiotic dosing, there are going to be three big areas. So one is talking about our rationale for use of high-dose amoxicillin and amoxicillin clavulanate in treatment of respiratory tract infections. I have a very brief slide on ceftamir, and then some discussion for management of antibiotic allergies. So I know it's a very small slide, but this is really just to orient that here's an example of one of the algorithms. So this is the otitis media one. We'll be going into this more in depth in our later slides. But specifically highlighting here that based on our patient, really first-line antibiotic choice is going to be either amoxicillin or amoxicillin clavulanate, dosed at 45 mg per kg per dose of your amoxicillin component either way. So why are we doing high-dose amoxicillin and why we try and feel strongly about this? So the idea behind high-dose amoxicillin is to really help and achieve those higher middle ear fluid concentrations to reduce susceptibility to strep pneumo. So I'm going to pause there to pull us over to the right side of the graphic. So the top slide, or sorry, the top graph is a probability of target attainment. So what this is what dose do you need to give enough concentration to try and make sure that you're going to have clinical efficacy, basically. And so typically we want to see probability of target attainment of, I'm going to say at least 80%, maybe 90. Uh, and so the higher the number, the better. And so what we see here is when you're using standard dose amoxicillin, so something like 20 mg per kg Q12, which would be like 40 mg per kg BID, While it is going to give you a very high probability for, say, an MIC of 1, so your MICs are along the x-axis here, your probability drops to 70 and then even lower than 40% when you have your higher MICs of 2 and 4. And so I think it's important the thing below is from CLSI. So these are our official breakpoints for our strep pneumo. So in an MIC of 2, those are all susceptible strep pneumo isolates. We say, yep, they'll be covered. Once you get up to an MIC of 4, it's no longer susceptible, but that's an intermediate susceptible strep pneumo isolate, and it's really not an MIC of 8 until you get resistance. But we find by increasing up the dose to say 40, 45 mg per kg twice daily, so that'd be the equivalent of 80, 90 mg per kg per day, high dose, for your amoxicillin component, we can get probability of target attainment above 70%, even for an MIC of 4, so even our intermediate resistant strep pneumo. And so while data directly comparing standard versus high dose amoxicillin is limited, we really feel that this PK and then just additional observational data, because I'd say this is not a new thing. We've been doing high dose for amoxicillin for a long time. And so using that as well as just observational data of when we decided to go and make the change many, many years ago, there really wasn't a shift in higher increased adverse events when we changed over to high dose. And so from our perspective, high dose is unlikely to cause more adverse effects, and it's more likely to cover all of your strep pneumo. And in this case, you're covering all of your susceptible 100%, and you're also covering most of your intermediate. So if they fail high dose amox, it's not that maybe you underdosed your amox. Like amox is just not going to work because whatever you're treating is either not susceptible to amoxicillin or the MIC is so high that there's no way you'll overcome it and it's going to be resistant. Because we're talking about that, I think it's really important, though, to say Amox, I think, is a little bit more straightforward, but one of the areas of a lot of education I do actually around for everyone I interact with is augmentin dosing. Regardless from the brand new residents all up to the very seasoned ID attendings, I feel like everyone is always learning more about augmentin, and it can be very confusing. And so a word of caution and hopefully some slides that you could also use if you needed to provide education to your other providers, because part of this is also giving you refreshers. So if you have to have those conversations with your ED providers, you're like, I remember that slide. Lauren had that slide for me. So there have been studies that show, as we might expect, increased GI side effects as your amount of clavulanate increases. And so importantly, the more clavulanate you have, the higher the risk of GI side effects. And so it's important to remember that when dosing it. I think one of the misnomers that a lot of physicians I've worked with have had is, oh, I'm giving high dose augmentin. And so because of that, I'm giving more clavulanate, but that's actually not true. You're getting the exact, if you dose them the way they're meant to be, so you're giving that 7-to-1 standard dose suspension at 40 to 45 mg per kg per day for your amoxicillin component, you get the exact same amount of clavulanate as if you were giving high dose at 80 to 90. The only real issue you run into is when you start deviating from these standards. So if you give a standard dose 7-to-1 based ratio formulation of augmentin at over 45 mg per kg per day, you're going to be giving more than that 6.5 mg per kg per day of clavulanate, very high risk of GI intolerance. And I'd say that upper limit that I've seen in literature is do not go over 10 mg per kg per day. It will be bad for the patient and for all involved. But also, I think importantly is the contrary wise. So what happens if you give high dose augmentin at less than 80 mg per kg per day? And so effectively, you're then giving less than 6.5 mg per kg per day of clavulanate. What does that mean? Well, I'd say there's not literature on the least effective amount of clavulanate that you can get away with. And I would question, if you're not going to give an effective amount of clavulanate, why did you bother giving augmentin in the first place? Because effectively, you're just giving amoxicillin with maybe a whiff of something that might give you a beta-lactamase inhibitor, but not guaranteed. So because augmentin is so confusing, one of the things I did several years ago is I made this sort of little step-by-step algorithm to try and help providers think through the different options. And so for what you're treating, you basically pick the indication you're wanting to use. Based on that, it gives you a little H or S or L to tell you sort of what dosing scheme you need to go with, whether it be standard, so the 40 to 45 mg per kg per day, or high dose, or the low ratio, because it's not really low dose, but I don't know what to do with basically the 4-to-1 formulation. And then based on that, what formulation you should be picking. And so you'll see that otitis media, sinusitis, and CAP are all included on here, and we all recommend high dose for these. Okay, number 3 is going to be Septinir. So I, like many ID pharmacists, am not a fan of Septinir, but I think that we're a little bit stuck with it because we have, unfortunately, fairly limited options for oral third-generation cephalosporins that are also liquid and also readily available in the community. And I think that's a bit of why we're sort of stuck with Septinir right now. So if it is going to be used, because in literature it's been shown to be less effective than some of your alternatives, I think it's really important that we use it appropriately. And so what has been shown in studies looking at dosing frequency is that if you give Ceftonir daily versus twice daily, you actually end up with regrowth of strep pneumo, whether it be penicillin sensitive or intermediate, least susceptible strep pneumo, within 24 hours if you're doing once daily. And so this is my reminder that if you have a patient with an allergy and Ceftonir is going to be given appropriately because they just can't do Amox or Augmentin, to please give it twice daily instead of daily because it has a higher chance of working in that case. Okay, learning point number 4 is going to be about antibiotic allergy. To make this a little bit simplified, because I think there's tons of resources that can be used. And certainly I think there could be a whole lecture on antibiotic allergy, and there's so much to cover in this, so I can only briefly touch on it. But first, I think it's important to acknowledge that although a lot of people say they have penicillin allergy, like less than 1% of those are true allergies. And so I think it's very important to scrutinize those allergies appropriately. And to then make it a little bit more simple, since we're all pharmacists here, so we have that knowledge, it's important to remember that when we're talking about beta-lactams, for our immediate type hypersensitivity reactions, those are going to be mediated by our R1 side chains. So similar R1 side chains are going to be more likely to have cross-reactivity, where dissimilar R1 side chains unlikely to cross-react for a type 1 allergy, and then for type 2, or for delayed type hypersensitivity, we just avoid beta-lactams altogether. And so I give some examples here. So things like penicillin, amoxicillin, very similar looking side chains, probably going to have a cross-reactivity, versus say something like Ceftonir, although it's also beta-lactam, R1 side chain, very dissimilar. But because while I also I have a pretty big medicinal chemistry background, so I enjoy looking at chemical structures, maybe not as easy to do when you're in the midst of doing clinical things. And so there are many, many resources that have cross-reactivity tables that people have put together. I have one here from Northwestern Medicine available just as a demonstration, but you can see here that where they have sort of a red X, there's definitely going to be a cross-reactivity. The yellows are little caution triangles, so you should be mindful. And just in a demonstration here that Amox and Ceftonir won't cross-react, so you'd be fine to use it. So how is this going to reflect in the algorithms? So within the algorithms, we have callouts on these sort of decision hexagons uh, of what to do if you have a patient with an allergy. And so for patients who have intermediate hypersensitivity or an immediate hypersensitivity to amoxicillin, penicillin, or cephalexin, we say you can use a beta-lactam with a dissimilar R1 side chain. In most cases is going to be Ceftonir for these algorithms. Versus if you have patients who have an immediate hypersensitivity to a cephalosporin other than cephalexin, unfortunately, we don't have unfortunately, we don't have another beta-lactam they can go to because there are no oral carbapenems, and I really want to use that in this case anyway. And so we're going to have to change to a non-beta-lactam like clindamycin or another antibiotic. And then finally, if you have patients who have a delayed hypersensitivity, in any of those, again, we're going to do a non-beta-lactam. Okay. So moving on to some algorithm reviews. There are 4 algorithms that we're going to talk about here, but in my mind, they kind of group into these areas. So we're going to talk about otitis media, sinusitis, and CAP first, sort of as one group, because the antibiotics are going to be similar. And then we're going to talk about strep pharyngitis. So I touched on it a bit, but why we're going to talk about these together. So one, otitis media, otitis media, sinusitis, and CAP have similar organism coverage needed. So strep pneumo, Haemophilus influenza, and Moraxella catarrhalis. These guidelines also have very similar recommendations around use of standard versus high dose amoxicillin and augmentin. And strep pharyngitis, you wouldn't use augmentin anyway. And then regardless of indication, standard dosing rules, as discussed before, should apply to augmentin. So first, we're going to talk about otitis media, and we're going to sort of go through it a little at a time, but I want to call out, instead of reading you the algorithms, because I think that you all will also be able to read the algorithms yourself, I really want to call out some key points that may come up in discussion with providers or things that are maybe not nuanced, but I think important things of these algorithms. So first is going to be this opportunity for watchful waiting. I've discussed with some of the ED physician stakeholders for this project, and while we recognize this may not be something used commonly in the ED, because it's something that's included within the algorithm, I want to just call out what it is and acknowledge where it could be used. A reminder, these algorithms are also being used for our affiliated primary care sites, so PCHA, and they're going to be using this all the time. So maybe not used as much in the ED, but would apply. So for our patients who have non-severe AOM, so what does this mean? Either they are at least 24 months of age, or they're 6 to 23 months and they don't have bilateral ear infection, they can be considered for watchful waiting and get what is a SNAP prescription. So what is that? So a SNAP prescription is sort of like a have this antibiotic now, but don't use it yet until you need it. Why for this? So a lot of ear infections just get better on their own in 2 to 3 days, like no antibiotics needed. And so one of the recommendations that has come out in many through the CDC and in recent years, it feels a bit awkward now to reference the CDC always, but through the CDC and in many recent years have suggested for these patients who either may have AOM because of a virus, or if it's bacterial, may also get it better on its own. Instead of ordering the antibiotic to start immediately for these patients who may not be as high risk for progression, to sort of wait and see how it does for a couple of days. But because you don't necessarily want to have the patient leave with nothing and you don't want to have them come back to office, you can send them out with an antibiotic prescription to hold on to with instructions about when to fill it. So two important things about this. One is patients where the SNAP approach is not appropriate. This is not as much for our ED pharmacists to worry about, but we're including as an awareness of what we're telling the our providers as well for like, these are not appropriate patients for SNAP. So patients with an immune deficiency or underlying anatomic abnormality, patients with tympanostomy tubes, ruptured tympanic membranes, history of resistant or recurrent AOM, and then patients with severe symptoms. And of course, if they have severe symptoms, they won't even be on the side of the algorithm. To help encourage this use of SNAP prescriptions, there's two things that we're going to do. First is we have a set of patient caregiver instructions that specifically have education around. So you're going home with a SNAP prescription, what this means, what to expect, when to fill the prescription. But also we're planning to include a little note to the pharmacy. This is not for our pharmacist, but the receiving pharmacy around this is to file, don't dispense until it's requested by the family. And that's part of my experience of working in retail is if you get the prescription in and there's no note, I'm just going to fill it immediately. And then it's a call to the family of, hey, your prescription is here waiting for you. And I think that's just going to encourage people more to just go and pick up their antibiotic now instead of actually trying to do any watchful waiting. Okay, so learning point number 2, we're going to talk about the duration piece. So for AOM, duration is going to be based on severity and age. So for patients under 2 years, we'll always get 10 days, 2 to 5 years, 7 days, and then 6 years and older, 5 days. For any of these age groups, except for the 2 years, who's going to get 10 days anyway, any patient with severe symptoms will should receive a 10-day prescription. Okay, we just pulled back out here, but we're going to go back down. This is going to be about our antibiotic choice at this point. So the first sort of decision nexus is around their sort of antibiotic history and other clinical symptoms. So for patients with recent amoxicillin use within the last 30 days, history of recurrent AOM that was unresponsive to amoxicillin, or concurrent purulent conjunctivitis where there could be a higher concern for Haemophilus influenza, for patients, so that's the decision nexus. If they don't have that, the choice is amoxicillin. If they do have that, then the choice is Augmentin. In any cases, you'll note that we sort of converge in the middle. For patients with allergies, if it's a penicillin, amoxicillin, cephalexin allergy, then it's going to be Ceftonir is our cephalosporin of choice. And if Ceftonir is not available or they have a cephalosporin allergy or delayed type, then clindamycin is your other choice. The other part I want to call out is I think you might see more frequently in the ED is patients who are just unable to tolerate any oral therapy. Those patients, as long as they don't have a cephalosporin allergy, could get a one-time dose of ceftriaxone. Certainly not the narrowest thing in the world, but they can't take orals. A one-time dose of ceftriaxone could finish them off. And then for patients who have a failure of Augmentin, Ceftonir, clindamycin, and it's been 48 to 72 hours, those patients should be given ceftriaxone. And this is where it's going to get complicated. It's for 3 days. I don't think that really works in the ED. This is more of a like a one-time see you there, and then they're going to have to go and get their other doses somewhere else. But acknowledging it's a part of the algorithm because we use this for PCHA as well, where it's possible they might have someone come back into the clinic a couple days in a row. Okay, next we're going to talk about is sinusitis. So to start off here, very top, something that I'd say is important, but also not important. All these algorithms are sort of designed around outpatient management. And so patients, as you would expect, that have suspected complications, including orbital or intracranial involvement, should be excluded from the algorithm. Those patients are getting admitted, so this algorithm doesn't qualify, but important to call out that this is not for them. But sinusitis, then, to categorize and classify yourself as acute bacterial sinusitis, need to have one of three presenting symptoms. So either persistent, worsening, or severe symptoms. If one of those three are true, then yes, we'll be treating as acute bacterial sinusitis. If no, it's a viral sinusitis, they get no antibiotics. So first, we're going to talk about duration. So for persistent or worsening symptoms, those patients should get 7 days. For severe symptoms, 10 days. And then choice. So for persistent or worsening sinusitis where they get 7 days, our decision nexus is going to be around these risk factors. So age under 2, immunocompromised patients, patients with recent daycare attendance, or if they've gotten antibiotics in the last 30 days. If these aren't true, then they can get amoxicillin. And this is going to be a little bit odd, and I have a next slide on it, but we either offer amoxicillin high dose or amoxicillin standard dose. But Lauren, you may ask, you just gave me a whole slide and a half on why amoxicillin high dose would be your standard. And so while personally I agree, if it was just me doing this, I would always give amoxicillin high dose. I do want to acknowledge that there is extrapolating adult data. There are randomized clinical trials that have come out comparing standard dose to high dose for 7 days, and they found no significant difference in clinical improvement at 3 days. So patients didn't actually need high dose in those cases. And the pediatric guidelines, although a little old, do say that high-dose amoxicillin is important in communities with either high prevalence of non-susceptible strep pneumo or in children with severe disease or risk factors for resistance. If neither of those are true, they do acknowledge it's fine to give standard. And so in discussion with a lot of stakeholders from both PCHAR pediatric clinics and the ED stakeholders, we have decided we're offering both as part of the algorithm, and we're leaving it to the clinician to evaluate and decide which is most appropriate for the patient. That being said, I personally would just choose high dose because for me, it's more straightforward if for some reason they come in for toxicity or not toxicity, if they have a recurrence of treatment where they come back in and it's like, well, they got amoxicillin and it didn't work. It's not a question of was the dose not high enough, it was the amoxicillin won't work. But okay, so then for persistent worsening, let's say they do have those risk factors, then the choice is going to be for Augmentin. In cases of severe infection, there's really no decision matrix. All these patients should get 10 days and they're all going to get Augmentin. And then just highlighting going through the allergy options, very similar. So if they have an immediate hypersensitivity to amoxicillin, penicillin, or cephalexin, those patients should get Ceftonir. And then if they have a cephalosporin allergy or any delayed type hypersensitivity, it's going to be levofloxacin. But you might ask, or you might get a question from a provider, why are we doing levofloxacin and not clindamycin like we did on the otitis media algorithm? And so importantly here, I think it's important to say the concern for our organisms is the same. We're still worried for strep pneumo, Haemophilus influenza, and Moraxella catarrhalis. This was true for AOM and true for sinusitis. Levofloxacin will cover all of these organisms. Clindamycin actually doesn't reliably cover H. influenza. There's also, we'll come back to that concern for sinusitis causing potentially intracranial infection, but I'm going to say in this is the scenarios sort of walked through as we were prepping the algorithms, but I'd say if you use clindamycin, the concern will be, well, I've used clindamycin as my only therapy. I may not cover Haemophilus influenza. To cover Haemophilus, I need trimethoprim sulfa because you're going to have variable strep pneumosusceptibility. I work so because as someone who works in pediatrics and you all too, clindamycin is not the best tasting thing, and trimethoprim sulfa is also not the best tasting thing. And I think the requirement to give two bad tasting antibiotics to a child is very, very challenging. And so we opted both weighing risk and benefits as well as just the volume of AOM we see and the potential increase we'd see in levofloxacin, that risk benefits wise, we felt for AOM, if they go out on Clinda and they fail Clinda, levofloxacin could be an option or something else to follow up with. But the worry of undertreating sinusitis and having it progress into potentially an intracranial infection was too great. And so that is why for AOM, we recommend Clinda as our sort of allergy alternative bottom line. And then for sinusitis and CAP, if you do need an allergy option, we recommend levofloxacin. Okay, and then the last of these sort of three pathways, we have CAP. So digging into this, the allergy option here is, I'm going to say, the most straightforward. If you don't have an allergy, you give amoxicillin for 5 days. If there is some concern for an allergy, you can't use amoxicillin. You're going to get clindamycin or levofloxacin. There are many exclusion criteria here. These are things that typically require inpatient admission. So again, really not outpatient management. But you might also question, I would say the ED is in an interesting situation. So a reminder that this is going to be used by our outpatient prescribers as well, who do not have an algorithm, but you are in an interesting case. You have an existing CAP algorithm. And so we tried very hard to make sure that this does not conflict with that algorithm, but I also acknowledge your existing CAP algorithm is much more in depth. Specifically, this under unimmunized cascade that exists within the current algorithm for CAP that you have. And so first to call out what this means. So under unimmunized are patients who are not appropriately immunized for Haemophilus B. So for Haemophilus influenza type B, we have found that I guess two factors for this. One, within our antibiogram, like 60% of those H. flu are susceptible to ampicillin, so you actually don't need augmentin anyway, so that's good news. But two, we found that for our PCHA providers, it was just a little bit too complicated to, one, evaluate all of their immunization status and what this means and all of that. So for the PCHA and the sort of simple algorithm pathway, left out the under-immunized cascade, but we do recognize that ED may see maybe more complicated patients as well. And so we want to make sure to call out that you have this other resource that has some additional recommendations. And so if you have a patient who's been on amoxicillin and Clinda and they haven't gotten better, it is very appropriate to consider an escalation to augmentin or doxycycline if you need an allergy alternative, because it may be that you're not covering Haemophilus influenza. Okay, and then finally for this, some caveats around treatment for atypical pneumonia. A call out. This is, so certainly you can treat atypical pneumonia if it's a really easy call, like I'm just concerned for atypical pneumonia, then this is not needed. Just give azithromycin, you're done. This is what to do if you can't tease out if this is typical, atypical, and you feel that both treatments are needed. In that case, for a patient who's on amoxicillin, add azithro. If they're on clindamycin, they're already on a second-line agent. Don't bother adding azithro, just change to levofloxacin. And if they're on levofloxacin, you have atypical coverage, no changes are needed. Other important caveats that I'll have here, I'd say more of this data is in inpatients, but the sentiment applies. For young children, It has been variably shown that treatment of mycoplasma actually gives any benefit. This is a little bit awkward in a time where mycoplasma cases are a little bit on the rise, so I know nationally use of azithromycin was increasing, but I'd say in kids, especially under 5, they may actually not get much benefit from a macrolide unless it's like an anti-inflammatory property. So if it comes down to they're not going to be able to take 2 medicines, they probably could get away with not treating it at all. But the other piece I wanted to throw out this is more of a conversation of you have a beta-lactam, do you need to have a macrolide added? Iffy, maybe not, especially under 5. But I do want to have a call here that under no circumstances should patients go out on azithromycin monotherapy unless you are 100% like, this is just an atypical pneumonia. I'm only treating mycoplasma. We're done. And that's because strep pneumo, especially not just nationally, but in our area as well, has very poor susceptibility. So in the US, 30% of strep pneumo isolates have high level resistance to macrolides. The updated adult CAP guidelines, because the PEDS ones are still sort of waiting in the wings for updates, recommend that don't use a macrolide as monotherapy unless your local pneumococcal resistance is under 25%. Well, our pneumococcal resistance is at 27%. So we're like around, again, that 30% in the US. And so if you're going to treat for a sort of typical pneumonia, azithromycin monotherapy will not even reliably cover your strep pneumo. So no azithro alone, no Z-Pak and done. Have to do dual therapy or change to levofloxacin. Okay. And then the last algorithm we're going to cover, and this one will be quick, is going to be streptococcal pharyngitis. I'd say strep pharyngitis is nice because it is 100% the most straightforward. So if you have a patient with no allergies, they should get either amoxicillin for 10 days, penicillin VK for 10 days, or they can get a one-time dose of benzathine penicillin, provided it's not on shortage. We're certainly struggling with that over on the peds side. So something I know that our ED providers have expressed a lot of interest in, but certainly I don't think a reliable treatment option right now. For patients who do have an allergy, your choices are either going to be clindamycin or azithromycin. There's really not a which one you should prioritize here because I'd say in general, resistance to both is sort of on the rise. So it's a bit of a toss up on which one will work. And we typically say if you can get susceptibilities, maybe you should, but that's a very ID thing as well. Okay, but a quick note on amoxicillin and penicillin. Some questions that have come up when we have discussed with providers, and so wanted to give education unless you also get questions on the providers. So one is once versus twice daily dosing. Within our algorithms, we recommend once daily dosing. That's because there's been meta-analyses that show once daily amoxicillin had no difference in efficacy in similar bacteriologic or equivalent bacteriological cure rates as more frequent dosing schedules. So if you can get away with once daily dosing, I wouldn't bother with twice. And then there has been some newer literature trying to evaluate shorter durations, like 7 days versus a 10-day course. But those trials are mixed still and have not consistently met bacteriologic eradication thresholds. And so for now, we're still sticking with a full 10-day course. But I do think that there may be in the future some room to reduce duration. The other thing to call out is that there are some existing guidelines that are a little bit strange. So calling out why we have no cephalosporin is, and if you go to, say, the CDC guidelines, which have been published for many years, some of the allergy alternatives they offer for penicillin allergy include cephalexin and cefadroxil. But again, calling back to the allergy thing we were talking about earlier, we were talking about R1 side chains. And so cephalexin, as we've called out with previous algorithms, has basically the same or very similar R1 side chain to penicillin V and amoxicillin. And cefadroxil has literally the same R1 side chain as amoxicillin. And so again, if we go back to that Northwestern sort of cross-reactivity table, you'll find cefadroxil and cephalexin are not appropriate alternatives for patients who have a true penicillin allergy or amoxicillin allergy. And so that's why on our guidelines, we don't have a cephalosporin included because if it's true allergy, you really shouldn't be using those anyway. And if they do have an allergy and you have been using those, I'd really question if they actually have that penicillin or amoxicillin allergy. Okay, and the final little bit I wanted to provide here, we've made it through the algorithms. The tiny bit I wanted to provide here is just very quickly some resources. So first, um, We have at LPCH an external ASP website where we host many, many, many resources. It can either be accessed through many ways, but I'd say we have a vanity URL. The QR code is there. If you want to be linked directly to it, I think if you also Google like LPCH ASP, it comes up. Um, but going through some of the things we have. So first, we have a lot of pathways and guidelines. I think as someone, the person who helps to manage the website, every pathway or guideline we have that has an antibiotic included in it, I have tried to have linked to this website. Also importantly, um, two of the things we have here, so all the algorithms we reviewed today are available. That's that blue box on the bottom. Also, notably, anything that has the word PDF after it, that should be externally accessible, meaning you don't need an LPCH login. It should just pull up on your phone, on your personal computer, wherever, no logins needed. And so that should now include most of our pathways as well as all of these algorithms. And importantly, the little blue box on the top is the guidelines for initial therapy for common pediatric infections, um, which I have a slide on later. We also have a lot of dosing and monitoring resources. Again, if it has PDF, it should be able to pull up. So that includes our azole antifungals, prolonged beta-lactam infusions, our general dosing antibiogram, but also that augmentin dosing guide I showed earlier, which we do try and actively update as needed. Um, so one of the things I called out, we do have this sort of big all-encompassing common pediatric infection guideline. We try and keep this updated. So don't save a copy, just go to the website because we just pushed through another update recently. Um, but this has treatment for, oh my gosh, everything under the sun, including meningitis and sepsis and everything else. And if we don't have the treatment listed, we typically link to a resource that does. And then finally, wanted to highlight another resource that we have on the website, which is a antibiotic allergy assessment tool. If you haven't seen this before, it is a red cap form that allows you to sort of bop through and say, hey, I have a patient. This is the allergy they do have. This is what I want to use. Um, when did it happen? What type of reaction with it? And at the end, importantly, it tells you what to do with it. So um, maybe an ED consult allergy isn't what you're going to necessarily do, but it can at least tell you, and it can at least easily tell you, yeah, this isn't of concern. Maybe I would do a test dose, and so maybe you do or do not want to try that, depending on the comfort of the situation the attending. Or it'll say, no, I think that this is very likely to cross-react. You need to call allergy, and then you can choose another option. And so the final thing I wanted to just provide here is some contact information for us. So we are here. We are happy to help. Again, this is me for those who may have joined late. I'm Lauren Puckett. I'm actually the outpatient ASP pharmacist. So I do a lot of inpatient related things, including rounding with ID, but I also manage our OPAT program, our transitions of care. I help with our specialty clinics. Would love to help connect with the ED more and help support our PEDS ED in that way. I'm also available. I work Monday through Friday and have an email there. I'm available on Volt as well. You just need to search for LPCH and microbial stewardship pharmacist. And it'll either be myself or Laura Bia that comes up. She's our inpatient pharmacist. So whoever's on, but I'm also very happy to help answer questions.